Hello. Hi, good afternoon, and welcome to the Black Doctor's 6th Annual Women's Health Summit. We're so glad that you can join us today for what definitely will prove to be an impactful day filled with moderated panels with our expert guests, patient advocates, researchers, and more. Today, we've got two exciting streams that we're going to share with you. The first two panels will go from 3 until 5, and then we'll switch to a new link where you'll be able to pick up for the following 3 panels. But let's get started without further ado. As always, you can get more information on the topics that we're going to be discussing today on Black Doctor, as well as our sister site, Black Doctor Pro. Today, we'll be talking about very important matters concerning women's health because, as we all know, May is Women's Health Month. So we're excited to delve into that topic. We're going to start off talking about Black maternal health. Then we'll go into a discussion about menopause and cardiovascular health. Then we'll go into our second session, and that begins at 5. And we're going to look at orthopedic safety. That is fitness at any age. I don't know about you, but my knees are sometimes talking to me. So I definitely want to hear more about that from orthopedic experts as well as fitness experts in that area. After that, we go into an exciting discussion, one that brings up a lot of conversations and emotions, and that's about the intersection between therapy and faith. And that'll be hosted by our very own Shameika Rhymes. And we will then go into our last session about HER2 positive breast cancer and what Black women need to know about that very important subtype. So without further ado, I am going to jump into the first panel that I'm moderating, and that is about Black maternal health. Very exciting topic, one that's very serious. And as we're on the heels of Black Maternal Health Week in mid-April, the conversation continues, not limited to a week, not limited to a month, but all year round until we get answers, policies, and solutions. So I'm going to welcome my panel. When they get on, I'm very excited for them to come on and introduce themselves as we go into our questions. And we'll be happy to take questions in the chat if there are some at that time and if time allows. Thank you so much. Hello, Dr. Denise. Welcome. Let's make sure you've got your mic on as we welcome everyone. Hello. I see you, Dr. Kim Thorton. So glad to have you on.
Good afternoon. Nice to be here.
To you too. All right. So we'll kick off the discussion. I think we're waiting for one or two more people who will come in as the panel begins. So I'm very excited about that. All right, so lots to get into here. So let's get started. First, why don't you guys introduce yourselves and tell everybody a little bit about your specialty and your connection to the topic today. I'll start with Dr. Kim Thorton.
So good afternoon. I'm Dr. Kim Thornton. I am a practicing reproductive endocrinologist at Boston IVF and EVRMA. I'm also the director of the Division of Reproductive Endocrinology and Infertility at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. I have been practicing, for over 30 years and have really seen the field of reproductive endocrinology, as it's grown, and, have some insights into how minority women in particular have navigated this space.
All right. Thank you. Thank you. All right. Definitely bringing the experience and the wisdom. So we're glad to have you on. All right. And let's talk to Dr. Denise Bold. Let's hear a little bit more about you. Oh, again with the mic. There you go. Oh, for some reason I can't hear you. Let me make sure if you got your volume all the way up. All right. Let me see if my producer can do anything with the mic and make sure that you're on. Unfortunately, I cannot hear you yet. I don't know if it's just me. All right, let's see. Oh, wait, hold on. Let me see. All right. Oh, I thought I just heard a noise. There you go. We'll work on that. Okay. All right, Dr. Thornton. So I'm going to begin with you.
Sure.
We hear so many statistics about Black maternal mortality. We hear about everything from the incidents that are taking place in the delivery room, after the delivery room, and also about stillbirths also within the delivery. Can you give us an overview of the state of Black women and maternal health, our outcomes in comparison to other ethnicities and racial groups?
So, yeah, I think I would be a little bit amiss if I talked about obstetric outcomes, because I am not a maternal fetal medicine specialist and don't practice obstetrics. I can speak to, however, the Black female or Black patient's experience in infertility, and recognizing that Black women, as compared to white women, have an overall lower fertility rate. They also seek fertility services almost half of the time. So, for instance, 8% of Black women seek fertility treatment, whereas, as compared to white and Asian women, where it's more like 15%. And the question is always, well, why is that? And from the standpoint of access to care, you have to think about where many of our minority patients live. They oftentimes live in areas where there aren't a lot of physician availability, and so that when they are seeking their physician, they're not necessarily getting educated about their reproductive outcomes and especially their fertility options. Oftentimes, Black women will present for fertility treatment at a much older age. And, part of that is based on the fact that there are, somewhat misconceptions that that Black women in particular have higher fertility. And so they're either not referred by the physicians that they are seeing, or they're not asking the right questions of their physicians when they walk into the physician's office. And so all of those factors kind of impact why women are seen less frequently. And then finally, there are a lot of comorbidities that Black women experience, and this is not only in the infertility space, but probably in the obstetric space as well, where they have a lot more comorbidities, whether it's obesity, diabetes, hypertension, the presence of uterine fibroids, tubal factor infertility, for instance, endometriosis, all of which have a negative impact on their fertility outcome, and oftentimes will need to be addressed before they can be successful in their efforts to conceive.
Got it. Those are a lot of factors that weigh into it. I mean, when you put all of those factors on the table, there's a lot at stake and a lot that's actually, weighed against Black women. However, we're still looking at the fact that how are Black women facing they're 3 times more likely to end up having a pregnancy-related death than white women. There's so many things that go into that number. Let's go a little bit deeper into it. I do want to welcome Dr. Denise Bolden back into the conversation. Denise, how are you? How are you doing today? Oh no, I'm not sure why we're still experiencing a problem. I don't know if it tested offline and worked well. All right, we'll go back, but I do see also that we've got Dr. Kimberly Gregory that we're also going to bring onto the stage right now. And there we go.
Can you hear me?
Gregory, how are you?
I'm great, thank you. How are you?
I'm wonderful. Well, we just got a few minutes into the conversation, but you're right on time. Would love to have you kick things off by telling everybody a little bit about yourself and your connection to the Black maternal health discussion, the important matters that we're having today.
It's great. I'm Kim Gregory. I'm Vice Chair for Women's Healthcare Quality and Performance Improvement at Cedars-Sinai Medical Center. I'm a OB and a maternal fetal medicine subspecialist.
I love that. So you, I know, have a lot to say about the conversation about Black maternal health and the outcomes. There was a number that I was repeating that was saying that Black women are 3 times more likely to die from pregnancy-related causes than white women. Is that something that, what are the numbers that you look at and hear about in your practice? And why does Black maternity and our outcomes and childbirth, why are they a crisis in the United States? And not just in the United States. I know the UK has a lot of numbers that are similar, a lot of other areas.
Right. Yeah, so there's no question that Black women do worse. And a lot of it is due to the prevalence of some of the comorbidities that are associated with adverse outcomes for everybody. So advanced maternal age, obesity, hypertension, cardiovascular disease, diabetes. These are all conditions that impact everyone, but we seem to have a higher prevalence of it. Stress, all of that relates to our birth outcomes.
Got it. So when you are speaking with women in your practice, do you get conversations or have conversations with Black women that come in? They're excited. It's an exciting time about pregnancy. But do they come to you with questions and almost fear, knowing the numbers that are out there? Are those discussions that you're having?
Oh my God.
Yeah, I'm just wondering, because when I think about
I feel like I do more.
Millions of years ago, I feel like I wasn't going to my doctor with a level of fear that I feel like I would actually bring now. Do you see that in your practice?
Yes, I feel like I do more therapy than OB right now. I have to remind people that, and the numbers are scary in terms of get it in proportion. They read the newspaper. You have to remember that there are 4 million births and 800 deaths. And of the 800 deaths, and there's another probably 50, 60,000 people who have complications or morbidity. But I try to remind people that the overwhelming majority of people actually do fine. And that birth is supposed to be a happy, joyful thing. And that if we sort of reframe what we're doing and think about it from a positive perspective, keeping conscious of the things that could go wrong, like the warning signs that the CDC talks about. If you have a headache, blurred vision, spots before your eyes, you're short of breath, you're just not feeling well, those things we should pay attention to. But, exercise, used to be that you were pregnant, we put everybody on bed rest. Well, no, we want you to move. And I think the more we normalize being healthy and that birth can be a good thing, the better it is for everybody.
Great. Let me bring Dr. Denise Bolds back in. Dr. Bolds, let's see how things go. Oh my goodness. I don't know why I'm not able to hear her. Is anybody else able to? Okay. Well, one of the things that's exciting, I hope we can bring her back because Dr. Denise Bolds is someone who is a doula, who also, I know doulas have also stepped into the stage for Black maternal health. And it's a really big, I guess a big portion of how a lot of the births are taking place right now. I'll ask you again, Dr. Gregory, how do you work with doulas when a new mom or a pregnant woman comes to you and says, I want to work with a doula? What is that conversation like between you and talking to them about how maybe the childbirth and delivery process would go? Do you work side by side with doulas at all? Do you just have conversations about what the options are with your patients, or how does that work?
I think every three-way interaction is a new three-way interaction. Some women defer to their doulas totally, in which case I'm always talking to the patient, but including the doula. Other times it's me and the patient, and then the patient talks to her doula, and then they sort of come back with their decision. So it really depends, but I try to be as, so it's almost like if you come to see me and you bring your mother or your partner, whoever's in the room is part of the discussion.
Got it. Okay, excellent. So, Dr. Thornton, I want to bring you back into the situation. So, I know that we talk about a lot of the conditions that Black women have, the comorbidities that come into it. When you talk about IVF and fertility conversations, why is it important to normalize conversations around infertility and reproductive health? Do you end up having kind of the conversations I was asking Dr. Gregory about, where are Black women coming to you later in life with looking for fertility options, with those options and some of the things, maybe endometriosis, fibroids, are you having to share with them that they may be more at risk for some of the things that we're talking about today? What are those conversations like, and how do you advise Black women of a later stage in life about pregnancy and their survival rates? I hate to say that, but yeah.
Right. So when I see a patient for infertility, and in particular African American patients, one of the things that you want to do is not only educate them about the fertility and their fertility options, but kind of provide them with some education as to what the testing that you're going to do means as it pertains to them. So, for instance, when if a patient walks in and is older, we talk a lot about ovarian reserve and how the fact that it's normal that as women get older, their ovarian reserve declines, and that it's my job to try to maximize their ovarian potential at the age they're at, right? Likewise, when we do the uterine cavity evaluation, if they have fibroids, we have a discussion about, do these fibroids impact their fertility? And then try to decide, do they need to be removed before we pursue an IVF cycle and create embryos, and then remove the fibroids before we transfer embryos back? Or are they young enough that they can have their myomectomy early? I had a conversation with a patient today who was just very anxious because she's reading online all of the negative things that are there, and getting worked up about things that she doesn't really have a whole lot of control over. We can control the things that we can related to her situation. So to try to refocus patients. The other thing is, many of the patients that I see, they're couples, right? So, you have to talk about infertility in the male, which oftentimes affects 30 to sometimes as high as 50% of the patients that we see. And again, normalize that. It's not necessarily, while it's an abnormal test result if the sperm count is low or if sperm motility is low, it's a fact of life in the general population. So we have to kind of meet people where they are and then provide them with the information about what treatments will likely get them to a successful pregnancy and work with them where they are. The other part of that, though, is education of physicians in the community, because it doesn't serve our patients well if they never get referred to a reproductive endocrinologist. It's important that the general OBGYNs, your nurse practitioners, understand, kind of what constitutes a fertility evaluation. When should that fertility evaluation be conducted? And when should the discussions about even, kind of reproductive life planning, when should those happen, right? The 30-year-old who walks into your office, you should have a discussion with the 30-year-old about what are your plans for building a family? Have you thought about egg freezing if you don't have a partner? All of those sorts of things. Looking at their uterus and making sure if they have fibroids, you decide, do they need surgery now, as opposed to waiting until their uterus is up to their belly button and, is too big. So those are all of the discussions that we need to have, even, when people are trying to conceive, so that they know what their options are ahead of time.
That is something, like you said, there's a lot of discussions there, and there's a lot of education that has to take place. Dr. Gregory, one of the things, though, in terms of outcomes for Black women and childbirth and the maternal health outcomes, income and education actually does not play into the success or the survival rates for Black women. What do you have to say about just the explanation on how women can be more prepared? What is it that we need to do from the patient standpoint, in collaboration with the doctors that we're talking to, whether they're ones that look like us or otherwise? What do we do to walk in to make sure that we're not that person that this happens to, and one, that it doesn't happen to anybody, but also that we put ourselves in the best position when we go to our doctors? If income and education and everything, doesn't have anything to do with it, how do we secure the best outcome for ourselves? $1 million
I wish it was that easy. A $1 million question, right? I would say that I'd like to, dovetail a little bit after what Dr. Thorton said. One of the things that I've sort of changed in my mentoring conversations is, you guys are here, you're planning your careers, but don't forget to plan your families and your, what you want your life to look like. There was, I think, a generation of us that was so career and focused on being successful that we, now I'm seeing them in my practice, like, oh my God, I forgot to have kids. And so the best time to have, so the first answer to your question is plan to get pregnant. And the ideal time to get pregnant is between, 25 and 35. Not to say that we can't take care of you after that, but if you want to do it at an ideal time, that's the ideal time. And then be as healthy as you can before you get pregnant. Exercise, eat right, lose weight, manage your blood pressure, get your hemoglobin A1C down. Those are things that you can do before you get pregnant that could optimize your outcomes.
Got it. Now, I do have a question. When I think of the mortality rates with Black women, I'm almost envisioning that these are all outcomes that are happening on the delivery room table. But that's not where a lot of these are happening. What is the trajectory? Where are the majority of the
majority happen after delivery, and the biggest majority happen, almost 6 weeks or more after the delivery.
Got it. And what is that? That's the complication that you mentioned before about the markers, like I have a headache, I'm not feeling great. Like, what is it if you're thinking you're out the woods, you've had the baby, you're 6 weeks home, you're doing all of the things. What is it that your partner, your family members, your doctor, your loved ones, what are the markers? What are the keys that people should be looking for that could leave you susceptible and have a negative outcome?
The CDC early warning signs, you tap it in and you can find them, but it's primarily headache, blurred vision, shortness of breath. So for example, you were saying, why does this happen? People will go to the emergency room and they'll say they're short of breath, but they don't tell them that they were recently pregnant or pregnant within the last year. So the ED doctor goes through his algorithms of shortness of breath without taking into consideration that, oh, if she was recently pregnant, I should be thinking about peripartum cardiomyopathy. Or you go in and they check you and your blood pressure is high. If you don't tell them you're recently pregnant, they're used to seeing people with high blood pressure. This isn't even an emergency for them. But in a recently pregnant woman, for whatever reason, our vessels are very fragile. So we can stroke at pressures that they think are routine for people with, quote, high blood pressure. So one of the things we've done is we've standardized a toolkit so that we treat everybody the same, like black, white, or purple. If you have an elevated blood pressure and you're recently pregnant, we want your blood pressure lowered within 30 minutes instead of, minimizing it and say, we'll get to it. And by doing that, we've actually decreased the maternal mortality rate for everybody. And the biggest drop actually came in Black women by standardizing the care. So then we found out that we have to not just teach OBs, we have to teach emergency room doctors. We have to get the cardiologist on board. We have to get family practice on board. And so because those are the ones who are in the ED, right? So we've made this sort of a multi-specialty issue. And a lot of that work has been done by the California Maternal Quality Care Collaborative and the AIM bundles, and in collaboration with ACOG and the Society of Maternal Fetal Medicine. And now the American Cardiology Association has joined us. So I think that we will see impact as we decrease the variation in how people are treated, and how when people get seen, they provide the information that they were pregnant within the last year.
So that's a really important takeaway right there. Right there, that's a big important takeaway, is like, you need to be able to make sure you let people know that you just recently had a birth.
Yes.
And that's going to be something that's going to trigger. But I love the fact that you're having a multidisciplinary team that's coming together and also alerting to the signs. And just to piggyback on that, though, does this mean that other ethnicities and other races do better of explaining themselves, or it's just, and letting people know, or it still feels like there might be a bit of a gap, on why is it that, is it just that we're not following up the right way? Is it that they're able to be forthcoming about it, or maybe people are just looking more? I'm wondering.
I don't have a good answer for you on that one. I'm sorry.
We'll throw that one out there. Now, Dr. Denise, I'm hoping that we can bring you in, because I know you've got a lot to share on this. I think we might be doing a workaround maybe on your audio. All right, let me see.
She's frozen.
There you go. Dr. Denise, are we doing a workaround? All right, trying to see if we can amplify you. Yeah, I was going to try and see if we had you on audio. Okay. So one of the things, though, mental health is often overlooked in maternal care. How does pregnancy and postpartum mental health uniquely affect Black women? I think I'm going to throw this one to you, Dr. Thorton. I know Dr. Gregory already said that a lot of times she's doing, mental health conversations and everything almost as much as her OB conversations. But with the conversations that you're having with the women coming in, I guess you're seeing people before with fertility. When you're talking to people about their mental health and everything going into it, leading into maternal health, what are the conversations that you're having?
Sure. So first of all, I can say that over the time that I've been practicing, I see a lot more patients who have just underlying anxiety and depression. And I don't know if that's the society that we're living in, but a lot of women are on antidepressants and anti-anxiety medications. That being said, I think it's important that as a physician, I recognize and differentiate those women with kind of your for lack of a better term, garden variety day-to-day anxiety versus those women who have very, very severe depression, where they've either been hospitalized prior to conceiving, have maybe a history of schizophrenia, or have had long-term history of long-standing depression. Because those women, oftentimes before I even initiate fertility treatment, I make sure that they are first plugged in with a psychiatrist who can review their medications, make sure their medications are safe for them to continue during pregnancy. Because oftentimes patients who have severe mental health issues requiring medications stop their meds during pregnancy because they feel that the meds are unsafe. And then they have a very, very high incidence of either complications during pregnancy or postpartum. And so postpartum depression is a very real thing, and you want to minimize the likelihood of those patients experiencing postpartum depression. So, I think for us to just, categorically stop all meds is not necessarily a good thing. You want to continue patients on medications if they are on medications that are safe during pregnancy, reassure them that they're safe during pregnancy. And then those women need to be plugged in with mental health providers, even postpartum, so you don't miss those women who all of a sudden, because of the massive hormonal swings, become very depressed. That's when you hear about women who have harmed their children or harmed themselves or their partner.
Oh my goodness. Dr. Gregory, how much are your conversations? I know we talked about just outcomes and people being concerned, but how much do you encounter postpartum depression with your patients?
It's not uncommon. It's more common than you think. So I'd say about a quarter of the patients, now whether they actually need medication or seek help, but at least I'd say about 25% will score positive.
Okay. So now, what is it that Black women can do, in your opinion, to be better advocates for themselves if there's concerns? They don't have a Dr. Gregory to go to as their OBGYN. They don't have a Dr. Thorton to talk to when they're in the planning stages. How is it that Black women can protect themselves from, having negative Black maternal health outcomes? How can they prepare themselves and really advocate among the medical team that they have? What do you need to do on your own? We talked about the physical things that you could do, but what about when you're there as an actual patient? And then also concerning, making sure the birth weight of your child is up. If we, all of the things that go into the 360-degree, pregnancy and birth and development. How do you make sure that you are actually protecting yourself, advocating for yourself, and have the best team around you, for you, in this case, to make sure you have safe delivery and life afterwards?
So that's like a loaded question. I think in the same way that I want to reiterate that, birth is joyful and easy, and most of the time it's going to be perfect. I want to say that you can do everything right. Your health team can do everything right. And still sometimes things can go wrong. Mm-hmm. That being said, I think if you walk in the room and the hairs on the back of your neck are standing up, you're not comfortable, that's not the right place for you. That's not the right doctor for you. You need to find someone that you feel comfortable with. And then when you find someone that you feel comfortable with, understand that that person's not perfect. They may have a busy day. They may have had something go bad at home. And so the same way that you step up for yourself when you're in the grocery store and somebody stands in front of you, you need to step up to your doctor and say, hey, wait, are you hearing me? I think that you heard me, but your response wasn't quite what I expected. And then I think we need to understand that sometimes when we say that I'm not being heard, it's because we're not getting what we want. And so if you're not getting what you want, you need to ask, is this the only option? Like, make sure that they're explaining to you what your options are. And then the best case, worst case for each of those options. Mm-hmm. And I think if you do that, In fact, I had somebody check me the other day, but she wanted to do something and I didn't want her to do it. And when I stopped and she said, you're not hearing me, I had to stop and say, okay, am I being defensive because she's not doing what I want? And when I thought about it and I thought about what she wanted, it was a reasonable alternative. It just wasn't my plan. So I had to, apologize and say, you're right. That's it. That's a not unreasonable option. It's not what most people would do, but it's not an unreasonable option. And, and I supported her care.
I mean, that's amazing. That's the kind of doctor that we all want to have, the one that we can actually bring our individual ideas to, and to be able to say, this may not be your choice, but this is what I'm thinking. Here's my reasoning. Can we talk about the medical pros and cons of doing it and make a decision together? And will you support me as my physician in my decision? And it sounds like that was amazing that you were able to step back and actually take that into account and like, you know what? We could do that. I wouldn't do that, but we can lay out all the medical reasons why that's perfectly acceptable for us to do. And if that's your option and what you want to do, I support that. And I think I love actually so many things of that scenario you shared, not only your response, but also when we're talking about patients advocating for themselves, that your patient actually felt comfortable enough to advocate for themselves, for herself with you, and luckily fell on the right, warm, ear to be able to listen to it. So I appreciate that. Dr. Thorton, one of the things that we hear about, and when we look at the numbers, we look at the statistics, it's hard to not see implicit bias and, culturally unaware, maybe physicians or medical people that are putting Black women at a disadvantage. What is it how much of a role do implicit bias and cultural incompetent care play in the maternal outcomes for Black women?
Yeah, sure. I think that we all carry with ourselves our own implicit biases over a number of different topics. So I think that first of all, as a physician, you need to understand if you have particular biases to recognize those, and we go through training to try to help mitigate those biases to the extent that we can. But one of the things that I've been involved with working with the American Society of Reproductive Medicine, for instance, is to increase or to champion efforts to increase the number of minority providers that are in the community in all of these, in our subspecialty in particular reproductive endocrinology, because I think that in many instances, even if you're seeing a provider that's not necessarily the same race as you, if within that practice, there are providers and staff members that, kind of represent your ethnicity, if you will, then oftentimes some of the biases that, the physicians may have can be dispelled because they're discussed within a practice, they're addressed in patient literature, etc. But I know in particular, the American Society of Reproductive Medicine has launched efforts to increase the pipeline of underrepresented minorities in reproductive medicine, physicians, nurses, mental health providers, embryologists, just so there's more diversity across our subspecialty. And I think that that's important. One, it's representative of the society within which we practice, but it brings that cultural competency to the practice and makes everybody more aware.
I mean, I think that's great. I think the more that we can bring cultural, we call it like culturally sensitive doctors, culturally competent, because unfortunately, I mean, our numbers of Black doctors overall is what, 5 or 6%.
Yes.
I mean, in terms of the population, we'll never be able to get the doctors. We can try, but we can never get the amount of doctors to meet the need of the amount of Black patients that, we can reach. But we have the opportunity to make sure that all of the doctors that serve Black patients and the Black community are culturally competent.
That's correct.
sensitive and know how to speak to our audience and address the needs that our community needs addressed on things like this. So, Dr. Gregory, I mean, we hear about things like policies and things or changes that need to happen on within the healthcare industry, within the medical community. Are there things that we should be doing? Are there things that Black physicians are doing? Are there things that people are doing to try to advance and improve the outcomes? We hear about certain policies and things that are out there, but is there something that we could do if we were to mobilize and look towards a certain direction? Or is it the local level? Is it the national level?
Why are your questions so easy?
And I'm saving them for you, just to.
So that, I mean, at the local level, and what is being disseminated nationally is standardization of care. So the more you standardize care, now it's the 80-20 rule, right? There's going to be that 20% of people who might need something different. But if 80% of the time you're doing the exact same thing, the exact same way for everybody, then there can't be implicit bias, right? If I treat everybody's blood pressure within 30 minutes, then I'm doing the same thing for everybody. And I think that those policies, that the AIM bundles and the state perinatal quality collaboratives are putting forth, are spot on for what we should be doing within the hospital. And then, I do think that we need to look at what's happening internationally. The better outcomes are happening in other countries, and they have a more integrated healthcare system. Many of them have a single payer system. And they incorporate midwives, they incorporate doulas, they have a family leave policy. And I think that those are, if you have a decent family leave policy, then you can take care of your family and do all the bonding that the newborn needs to get them off to a good start. You're not stressed about getting your job back. And you can take care of your intercurrent health issues, right? You can lose that weight between pregnancies. You can get to the cardiologist if you had preeclampsia. You can get to your internist to manage your blood sugar. You might even be able to start an exercise program. So I think that we need to decide that pregnancy and childbirth and raising a family is important, and then put the resources behind that in order to do it.
I love that. Dr. Denise, I know we talked about doulas and midwives. I was going to say, let's test your mic again. And the other option is for you to call me on the number there, and we can try to put you on speaker as well.
I don't know. Can you hear me now?
We can hear you. Yes.
Oh, hope springs eternal. God is always present. I'm so glad to be here. Yes. I'm Dr. Denise Bolden. I'm a high-risk doula here in New York City. I've been a doula now for 12 years, over numerous births in the health industry for 41 years. I'm the owner of Black Women Do VBAC, and I'm here to answer your questions. I'm so excited to be here.
Yes. Okay. So wonderful. So one of the things that we hear about is that a lot of Black women are choosing to have a doula now, and a lot of it is due to the Black maternal outcomes being negative, the numbers, the horrible statistics. Tell us a little bit, what is it when we're choosing a doula? What are we exactly doing? What's different? What does a doula bring to childbirth that is different from our OBGYN, our hospital delivery? Let's start there and level set for the audience.
Okay. Well, first of all, a doula is a non-clinical entity in maternal health. So that simply means that the doula is there to provide the non-clinical scope of this practice of childbirthing, understanding childbirthing education, as well as postpartum. So as the doula, I'm coming in to be that family's advocate. I'm coming in to be that presence. I'm coming in to be that connection. I'm coming in to be that community linkage to resources and opportunities. I'm also coming in to bear witness for them, to affirm if they've been traumatized prior, if they've had any kind of adverse experiences, as well as to help them remember, as it's been said on this panel earlier, to help them celebrate that this is a miraculous event. This is a joyous event. But for Black women, we do tend to have more of a preparation for the weathering effect, for the untoward, for the bias, for the racism to happen. So as the doula, I'm there to provide comfort techniques. I'm there to provide resources and education, as well as to save space for shared decision-making, so that family, that person giving birth, feels that they're contributing to the birth process, and it is just not a clinical focused event.
So that gives us so much there to that and so much to unpack. It sounds like for a lot of people, like adding a doula is something new, but historically, having a doula or midwife or someone, that's not something that's uncommon, right? And tell us a little bit about the history of incorporating a doula, and are Black women, how are we in terms of embracing it? Is this new for us? Is this going back, and bringing back something from a different time? Or do you find that people kind of look at you with awe when you talk about what you do and what you bring to the process?
It's a little bit of both, and I love this question. It's a little bit of both because from a generational aspect, I come from a Southern lineage of maternal healers. So the doula concept has always been here. In the South, we always had a group of women that would take care of the pregnant person. And even if that pregnant person didn't make it through the birth, then the group would also nurse that baby and get that baby to adulthood. So there's always been that community approach when it came to childbirth, when it came to pregnancy, when it comes to postpartum recovery. That community contribution has always been there. So doulas have been around forever, even though the word doula is a Greek word meaning a house servant in times of maternal health, childbirthing, and postpartum. Doulas have been around forever, and doulas have evolved from the Black culture from the grand midwives. When our ancestors came over on these slave ships, they literally first went to breeding plantations, and we had experts from these other countries bring their knowledge, values, and skills of childbirthing, of recovery postpartum, and started the breeding process of the gross national product known as slaves in this country. So therefore, we had this beautiful tapestry of understanding childbirth and understanding the necessary connection that's necessary for our people in order to thrive. This country was built off of Black bodies being bred purposely for a gross national product. So doulas have been around forever. Now, for more modern times, it was seen primarily as a white benefit, as a luxury. But Black people, people of color, we've been pulling in our aunties, our sister friends, our soror sisters, everyone. We've been pulling them in forever to help us have our babies safely, because we need that presence in a medical system that is predominantly white, that was not built for us.
So that is a historical perspective that I don't think many of us knew all of the details on. I don't know if you were on when I was asking Dr. Gregory about how does the partnership with her and doulas come together. Dr. Gregory, and for Dr. Bolden, do you find, is there any pushback or hesitation in terms of working, this whole family advocacy, being the family advocate, being there for comfort? Does that ever clash, having the doula there and the doctor there and the patient? Is it too many, not cooks in the kitchen, but is it too many people that are there? Is it a difficult dance? Or maybe even, Dr. Bolden, do you find there's any resentment that you get from an OBGYN? Like, why are you here? I've got this. You know what I mean? Like, it sounds like Dr. Gregory was saying earlier that she's welcome to the opportunity and they've come together. But do you get hesitation, Dr. Bolden? And then I'll go back to you, Dr. Gregory, on, again, if there was any, information or any situations that you've had that were very positive or very negative, I guess.
First of all, I do get some pushback, and there are some clinicians that are not doula friendly, as we would call them. But when I see a Black physician, my heart swells because I know their background. I know what they had to go through to get that white coat to be put over their shoulders. I know the dedication and hard work. I know the ruler, the bar was so much higher for them than their other fellow peers going through med school, going through their residency. I know the challenges. So when I see a Black doctor, it's much respect, much love. However, the times that we're in now, post-COVID, dealing with the type of environment in the medical arena that we're dealing with, many doctors are overextended and stressed. And so I do give a lot of grace with my clinicians. I do teach my families to understand the difference between an obstetrician and a midwife. An obstetrician is really focused on the complexities of pregnancy. And oftentimes that's how they're trained to think. So coming more from a holistic measure, a home birth, birth center birth, it's a little different when you're dealing with a high-risk pregnancy that requires hospital supervision. So I train doulas to understand those differences. I train my families to understand those differences. So we're coming in with a really good lens of respect and understanding of the OB, of the midwife, of the doula, and each one of them has a subsequent important role of being able to work together. So when I see a Black physician, when I have a Black birth, I call it the Black oasis. That means a Black family, Black nurse, Black doula, Black doctor. I always take a picture and it goes viral because this is a beautiful joint. That happens, it's magic in the room. So I have great respect for our physicians of color, but do I get pushback? Yes, because the institution sometimes creates that culture of skepticism and actual territory and ego. Yes.
Got it. Dr. Gregory, I would love for you to weigh in on it. Have you, are there any times that, have you ever said, I don't think this is the right birth, like high risk pregnancy or something, to maybe bring in a doula? Have you had all positive interactions? What would you say just to Dr. Denise in her comments?
I think that her perception is correct. There are, if you go to national meetings, there's some brouhaha about doulas. The studies, though, are pretty clear that there is a benefit. I mean, having a supportive person with you. And so I go back to what I said earlier. It's always about the one-on-one interaction. And so and then, as the captain of the ship, your job is to get along with everybody and make sure that the mom and the baby have the best outcome. So, my suggestion is always to be as non-confrontational as you can. And then there's sometimes when you realize, you have to stop the penicillin. An example would be plan this nice natural birth and went naturally, so I did it. But if you're in pain and you want something and your doula saying, no, that's not what we agreed to, sometimes you have to ask, and so when you then start to incorporate a full conversation, sometimes the patient can advocate for herself as well as have the doula advocate for her.
Got it. I love it. So it's really, it's a combination. It's a collaboration. It's really making sure everybody is putting the mom, the baby, into the center of everything, her comfort, her happiness and wellness, and everyone's on the same page. I love that. Before we wrap up, Dr. Thorton, just wanted to see if there's one message you have for either Black physicians, for Black mothers, for people advocating, or for mental health. What's your message, the takeaway that you want people viewing to have about how they can improve the outcomes or just have a better situation?
Sure. One of the things that I didn't get to mention is advocacy. And when you look at fertility care in particular, Oftentimes, depending on where you live, you may or may not have insurance coverage, but there are a number of different organizations, whether it's, again, the American Society of Reproductive Medicine, Resolve, and some of the smaller local organizations that can advocate for infertility coverage. And more employers are listening, and more insurance companies are listening. So that improves access to care. And with the improvement of access to care, you're going to also potentially improve outcomes because patients will be able to seek treatment earlier at times when they're going to have better outcomes.
I love that. I love that. Dr. Gregory, any parting words? Takeaways, key takeaways.
Have your babies early. Have your babies early.
And your outcomes, the successful outcomes improves.
That's
right?
correct.
I love that. All right. And Dr. Denise?
Yes, so a doula is a great investment in your maternal health for advocacy and education, whether it's fertility, whether it's for childbirth and postpartum, as well as what we didn't talk about here today is breastfeeding. Breastfeeding is also another big challenge when it comes to Black women in this country. So having a doula is really going to help you, and that doula can fit in exactly where the institution is, combined with where the family is, and coming to a really good, safe place for everyone to have a great experience.
I love that. Can you tell us how we could find out more about doulas?
Yes, you can just Google Denise Bowles, Bowl Doula. You can Google so many different organizations. There are over 277 organizations in the United States that talk about doulas. So if you're looking for anything from a Christian doula to a doula that has a different cultural background, different language background, different religious background, there's a doula that will be able to fit for you. So just put it into your Google or your chat or your Claude, and you are going to find them because we're out here. And Black Women Do VBAC also has a directory of doulas as well that you can find. But doulas are waiting for you to find them. They have put themselves out here. So go ahead and do the search and make sure that you're very specific on what you want, because this is a very big step in your life and it should be personalized for you.
I love that. I don't think we could leave on a better note. I want to thank all of my panelists. I really appreciate you being here for the Women's Health Summit. Dr. Thornton, Dr. Bolts, Dr. Gregory, thank you so much. As always, you can get more information about Black maternal health on blackdoctor.com, and definitely follow these ladies on social media. Do your research, and definitely let's work together to try to improve Black maternal outcomes. Thank you so much, ladies. I appreciate you.
Thank you. It's been a pleasure.
Thank you.
Thanks to meet all of you.
Welcome back, everyone, and thank you for continuing to watch Black Doctor's 6th Annual Women's Health Summit. I'm your host for this hour, Shameika Rhymes, and if you have any questions at all, please drop it in the chat. For this conversation, we're talking about menopause and cardiovascular health. Menopause is often described or talked about in terms of hot flashes, night sweats, mood changes, and reproductive health, but the heart deserves just as much attention, don't you think? Well, for Black women, this conversation is especially important because heart disease, high blood pressure, and stroke already impact our communities at higher rates. So today we're going to be looking at how that menopausal transition can affect our heart health and what symptoms women should pay attention to and how to better advocate for care during this stage of life. So let me introduce you to the panelists. I'm so excited about this. Joining me today, we have Dr. Darlene Thomas. She is a health and wellness consultant who supports women through midlife and menopausal transition. Welcome, Darlene.
Good morning, or good afternoon, I shall say.
Good to see you again. And forgive me, I feel like I'm going to mess this name up, but hopefully she'll set me on the right path. Dr. Kimberly Derezil. She's a double board certified physician, Menopause Society certified practitioner, and founder of Meno and Money. Hi, Dr. Kim. Did I do that right?
You did. You did a great job. Good evening, everyone.
And Dr. Eboni January is here. She's a board certified OBGYN surgeon, author, and women's health equity leader. Welcome, Dr. January. Oh, hold on. You're on mute. There we go.
Oh, thank you for having me.
Good to see you again.
Likewise.
And Dr. Kristin Cosby-GaitherShanta, she's the founder of A Stroke of Grace. She's also a stroke survivor, educator, and national health equity advocate. Welcome, Dr. Kristin. Oh, you're on mute.
Are we good now?
Yes, I can hear you now.
Hello. Thank you for having me.
And Shanta Quilette, you've seen her around here before. She's a speaker, best-selling author, patient advocate, and women's health storyteller whose journey includes perimenopause, stroke, and heart attack survival.
Hey, how y'all doing?
Hey, good to see you.
Be here, child. In so many ways.
Thank you all so much for being here and joining us for such an important conversation. So I thought we would kick this off with, this question is for everyone. So I think we'll just kind of do a round robin. And then as we go on, I'll direct the question to one of you. And then, you know, if others want to weigh in, stop me, be like, shut up and just jump in. So, all right. So everybody, to begin, how would you describe the connection between menopause and cardiovascular health, especially for Black women? Dr. January, I'm going to start with you.
Yeah, sure. You know, it's interesting because we see a lot of the physical symptoms, but it really is a cardiovascular checkpoint that not a lot of people pay a lot of attention to because we're so focused on the hot flashes. We're so focused on the weight gain, you know, the external things. But this is a critical point in a woman's life where your cardiovascular risk, your cardiovascular health, it takes a turn for, it could be the worst. So your risk goes up quite a bit, especially for Black women, because the fact of the matter is we're already at risk for high blood pressure, stroke, obesity. We have this chronic stress that we're dealing with. So you add that on the top of the fact that our estrogen levels have dropped, and that increases our cardiovascular risk. So it really is a cardiovascular checkpoint. So anyone listening, I want women to know that when you're going through menopause, this is the time to go ahead and start getting your heart checked.
Thank you. Dr. Kim, because I don't want to tear your last name up.
That's okay. Dr. Kim is great. Absolutely. So this intersection is really a unfortunate, like perfect storm, because one, you have this menopause journey that's happening. It's inevitable, whether you're going through it naturally or surgically, where your body is changing, and that's a lot to deal with. And then you have about 6 in 10 Black women over the age of 20 who's already living with some form of heart or blood vessel disease. So you add that two together, heart disease becomes a huge burden for all women, but especially for Black women. Mm-hmm. And so it's like Dr. Eboni said, it's a great checkpoint to be able to just check in with your numbers, check in with your provider to make sure that you are looking at the whole picture to ensure that the heart is healthy.
Okay, thank you. Dr. Darlene.
Yeah, I would also echo what Dr. Kim and Dr. Eboni spoke about. I also think too that, menopause is still looked through a reproductive lens. And so a lot of women will go to their gynecologist and they are just focusing on the physiological changes and not thinking about how this decline in estrogen affects multiple organs in our body, the heart being one that's really important, right? And so when you are aware, which is what we're doing today, which is educating women, when you are aware of some of the symptoms that might overlap with sort of a cardiac risk, then you are educated enough to ask for a cardiac assessment. And I think that's what we have to educate our community about. If you're having prolonged or persistent palpitations, or you're feeling dizzy or lightheaded, it doesn't have to be menopause related. It could be a cardiology issue that you need to have assessed, which is actually what happened to me as an athlete. So I think having this conversation is really important for women to know what those risks look like and when they should ask for an assessment beyond their gynecological check-in.
Okay, thank you. Let's see here. Dr. Christine.
Yes, I'm going to agree with everyone, what everyone else has said. I want to ditto that. And I would just say, as a stroke survivor, and I suffered a stroke when I was 35 years old, but as a survivor, I will say one of the things, especially we as women don't do, we don't pay attention to our bodies. We put everyone else first. We put ourselves last. And I just think that, like someone said previously, this is a checkpoint. Menopause is a checkpoint that you can then go back and look at your body, because that is something where it's almost like it's been put out there that, hey, this is the time you need to check on yourself. This is, I'm giving you a warning, check on yourself, because we check on our kids, we check on our husbands, we check on our spouse, whatever. We check on everyone else, and we always set ourselves last.
Mm-hmm. Mm-hmm. Thank you. Dr. Shanta Quilette. I have to tell you, when I was getting dressed, I just kept thinking, one thing Shanta you're going to do is put on clothes. And I was so tickled, but you look good. What are your thoughts?
Yeah. Listen, that's the most I can do. But yeah, so here's the thing for me. Menopause is a natural occurrence that all women are going to go through. Then cardiovascular disease is the number one killer of human beings, right? And so Black women are already starting from a more vulnerable place. And as a patient, I remember not connecting the two at all. Nobody told me that what was happening with my hormones was also happening to my heart. And so I had to find that out on my own. And so the gap between what medicine knows and what patients are actually told, that's exactly why I do this work. And just to piggyback on what Christine said, you as women, we have to be an active participant in our own rescue. And so it is important that when you do go to the doctor, you ask the right questions and don't allow those things to be dismissed. Because here's the thing, I don't want to go to the doctor now and just be told it's perimenopause. Or it's menopause. I want to be able to know, okay, doctor, let's rule everything out. My menopause may not be, it may not be menopause. It may be diabetes. It might be high blood pressure. It may be some cardiac issues. So just making sure that you advocate for yourself in all ways. And I have to do that as an advocate, and I also have to do that as a patient.
Thank you. Dr. Kim, menopause is often viewed mainly through a reproductive health lens, as we've kind of mentioned right now. So why do you think that heart health continues to get left out of this conversation? I can even say I was at the doctor yesterday and I was like asking, why are the numbers going up? When I was here this last time, it wasn't. And I was like, is it related to perimenopause? And the answer was, oh, no. But then there was no further discussion.
Right. Mm-hmm. Someone already alluded to this, but I think just across the board, menopause is considered this reproductive stage or the end of the reproductive stage where, okay, we know it as, women are stopping to, or no longer having the ability to have kids. And the symptoms that come along with it are the ones that are the most frequently heard, like the night sweats, the hot flashes, what they call collectively as vasomotor symptoms. So those are the primary reasons why most women are showing up to the doctors. They can't really function when they're not feeling 100%. And so everything else, I think, gets to be pushed to the side. Whereas the heart and what's happening with the heart, with the hormones dropping, that's not so easily visible. That's not so easily felt. It's like a very slow, gradual, silent change that's happening to the heart. That's just not being, that perspective is not being offered and discussed in the office, unfortunately. But this is, now having this conversation, and we're educating our group. This needs to be brought to their attention. This is part of like advocacy and bringing this to the forefront to let women know to, hey, not only do your symptoms need to be checked, but let's just check all your other primary organs, especially the heart.
Okay. Does anybody else want to weigh in on that one before I go to the next question?
Yeah, I will. It's simply stated, hot flashes get the attention, but that blood pressure, that's what can take your life. And, when you think of it like a machine gun. Getting hit in so many different ways. You're getting hit with the hot flashes. You're getting hit with the brain fog. You're getting hit with, just your joint aches. You're getting hit with all of these different things. But that cardiovascular issue, that's the sniper. That's the thing that you don't see. That's the thing that will really take you out. It's very calculated. And so that's why it gets so overlooked, is because we're getting hit with these machine guns of symptoms, and that's what we want to focus on, right? But the symptom that we can't feel, that we can't see, that's extremely calculated, that's the cardiovascular issue that it takes, a backseat to the things that we can treat with a pill. Right. And so that's what I would say, that hot flashes get the attention, but the blood pressure, that's what takes your life.
Yeah. Well, and also I will add to that. So yes, hot flashes get a lot of the attention, but some of the newer science also associates hot flashes with being a cardiac risk. So they're not benign. Mm-hmm. And for Black women, we tend to experience this journey. Not only do we start it 1 to 2 years earlier, but we tend to live in it longer. So women should not just ignore hot flashes and say, oh, it's just a hot flash, because there's a lot of research now that connects them as a risk to cardiovascular risk.
Absolutely.
Thank you.
Yeah, I also think that there's still a lot of discomfort around discussing it openly, culturally, generationally, clinically. When an entire topic gets minimized, I think sometimes cardiac risks never get a chance to surface in the conversation. And also, I feel like medicine puts our bodies in subsections. So you see a gynecologist for menopause, and you see a cardiologist for your heart, and rarely does anyone sit in the middle connecting those two. So I really think sometimes the system isn't built for whole person thinking, and that's why so many patients fall through the gaps when it comes to specialties.
Mm-hmm. Absolutely. And then when you think about this, you think about having to take off work for all of these different specialties. I got to go get my joints checked. I got to go get my hormones checked. Oh, now I have a cardiovascular issue. So, one of the things that I have done is my company partners with different organizations to make sure that organizations know what women are going through with regards to menopause, with regards to pregnancy, and have those parameters and protocols in place so that they can go to these different doctors' visits. It's not like they can go to 5 different doctors in one day. Maybe the other doctors don't necessarily have an appointment. So, it's so fragmented that we have to understand that, just as individuals, as employers, et cetera, because it really is a lot of different symptoms, and it affects every single organ system. I almost call it like the preeclampsia of menopause, right? Preeclampsia affects every single organ system, and menopause does as well.
Thank you guys for that. I wanted to go talk about, from the wellness and behavior change perspective. Dr. Darlene, what do you see women struggling with most as they navigate menopause, aging, and long-term heart health?
Well, I think when I meet with a lot of clients, of course, their initial concern is weight gain, right? But I think what they don't often connect to is the visceral fat that they're getting around the middle, and that fat is deeper in the organ. So a lot of time when I'm educating just in general about the symptoms, I'm often trying to get them to not focus so much on the number on the scale, but to focus on their health in general, and then what it means to actually have that additional visceral fat around the middle, right? Because that also increases their cardiovascular risk. However, when I am talking to them about lifestyle changes, we do talk about healthy eating and what that looks like, especially during menopause, because it also affects your gut. So the bloating, the gas, sometimes you just need to change your eating regimen. Exercise. So we also know from the science that the more muscle on your body lends to a healthier brain, because the muscle is a metabolically active organ. So I know there's a lot of influences out there talking about lifting heavy and all this, but really it's about moving your body and putting some resistance on those muscles so that not only you maintain muscle mass, but that you can gain and stay strong. And then the other thing I would say is helping them manage stress, because stress exacerbates all of these symptoms. And the most important one is sleep. So I think a lot of us, I know I did this when I was younger. I just negated sleep. I went for years, in my corporate life, just living on very few hours of sleep. But once I really started learning how important that is to heart health, brain health, I really started dialing on my sleep. So those are really the things I focus on when I'm talking about lifestyle changes, and really trying to get women to just not pay so much attention to that number on the scale, but think about their health and their longevity.
Thank you. Does anybody else want to weigh in on that from that perspective?
Yeah, I wanted to say, I'm sorry, excuse me.
No, go ahead.
Piggyback off the doctor, because it's so important to make sure that you know your body and you are eating right. I just recently had a whole panel workup done and realized that some of my caseins levels and all these things were disrupting my body. Eating dairy and gluten has sent my body out of whack. So in that, she says that my brain fog increases, my hot flashes increases, all these things have increased because what I thought was pretty much eating healthy has actually been a counterattack against my body. So it's really important when you do talk to the doctor, you ask for, specific tests that may help you mitigate the symptoms of menopause.
Thank you for bringing that up, and welcome to the gluten-free train. I will. If you need some recipes, I'm here. I had to kick gluten too.
Good, honey. Do they got ribs in them?
Absolutely not. Dr. Kristin, was that you that was wanting to?
Yeah, I was just gonna say one of the things that I do is I work. I'm a huge advocate on prevention, and especially stroke prevention. And these lifestyle changes that we were just talking about, everything is spot on. It's about eating better. It is about moving your body. I just encourage persons to move every day, whatever that is. If that's 15 minutes, if that's 30 minutes, move your body. Do something to move your body. Also, that stress thing is huge. I did not know how important it was until, honestly, when I had the stroke. I had a stroke. I was 35 years old. So I just thought I was living life like a normal 35-year-old. So, I never knew until after that happened, the importance of making sure you move your body. Stress, having something to alleviate that stress, whether it's journaling, meditation, whatever that is. But to do something in order to, assist in those lifestyle changes, because honestly, when you're 30, that's not something that you're thinking about. So it's really all about prevention. And I talk through that in prevention and especially lifestyle changes.
I agree with essentially everything everyone says. It's all about prevention. Many times we're very reactive in our approach to health and not proactive. We know that these things are going to come. We know that menopause is coming. So we have to start creating these good habits now. I always tell women, especially when I'm speaking about menopause or during my master classes, is that 2 things that you can control that is going to change your whole life within like 7 to 14 days. And that is, if you make sure that you take control of the first hour of your day, that means meditation, prayer, yoga, whatever, just set the stage to decrease that stress. And then second, you have to control your sleep. Your body needs time to reset. It doesn't matter how much we move, how much we improve our diet. If your body doesn't have time to reset, those cortisol levels are going to go up, and you're going to continue to be out of whack and wonder why you're fighting against something. You're doing all of the things, but if you haven't had time to reset, then none of that is going to be able to be as effective. So you have to control the first hour of your day, and that means making sure that you're calm, you're using yoga, journaling, whatever it is for you. And then that last hour before you go to sleep, to make sure that you have good sleep patterns to reset your entire system.
Mm-hmm. Thank you.
I think Eboni said something really important, which is, catching our community when they're younger. Because I think a lot of us are reactive, and it starts with the weight gain, unfortunately, because we're, as women, all brainwashed that we're supposed to look like a stick. However, one of the things I love about working in the clinic that I consult with is because I get to talk to not only women that are entering the sort of pregnancy phase of their life, but also postpartum. And I get an opportunity to start talking to them about the next stage of their life and what that looks like, and help them start developing these habits so that it's not shock to their system. Because as we're all alluding to, menopause affects everything. And so when I start educating women, I'm telling them, you got to do this, you got to do this, and that's overwhelming for them, right? So if you can catch them early enough to say, hey, what about your sleep? It's really important. Or as Dr. Eboni said, what about, having that practice in the morning where you're, meditating or doing your breath work, or helping regulate your system. These things are all important because they pay off later in life. And so it's really important that I think as a community, we start, going back a little bit and getting those, late 20s, early 30-year-olds to say, hey, because I think, as someone said, if you have a uterus and ovaries, it's coming.
Yeah. I wanted to go back to something Dr. Christine mentioned about being 35. As we're talking about that 30-year-old type of the 30s range. But I wanted both Dr. Christine and Dr. Shanta Quilette to talk about their experience, because both of you are bringing this lived experience as stroke survivors. And then, and Shanta Quilette, we've talked about it on Celebration about, the heart attack as well. So what do you both want women to understand about the connection between blood pressure, stroke risk, aging, and menopause? And if you could just like a quick summary of what happened when you experienced this.
Sure. I'll start off January 28, 2019. At the age of 35 years old, I suffered a massive stroke. I experienced 2 blood clots. I had one in the back of my head, one in the front of my head. And I was given a 5% chance of living. I could not walk, could not talk, was blind, paralyzed, still paralyzed on the right side of my face from this side over. But they've taught me through intense therapy how to speak and how to use my tongue to enunciate my words, even though I do not have any feeling in my tongue. I was in the healthcare system, both inpatient and outpatient, from January 28th to December 30th of 2019. So I was there for 11 months. I saw a lot of things when I was in the healthcare system, which is why I really ultimately founded this organization. This organization is called A Stroke of Grace. A Stroke of Grace is an organization that supports Black stroke survivors. We are the only organization in the United States that with a mission to support Black stroke survivors, because I have a burden for my people. I have a burden for people who look like me, and I want to prevent anyone I can to try from going through what I went through. And I'm still going through. I'm still on this journey. I still have issues with my balance. I still have issues with aphasia. My aphasia is not as bad as it was in the very beginning. But I still have a lot of issues, which makes me able to relate to a lot of stroke survivors because, hey, we've been there. I've been in the wheelchair. I've been in the cane. I've been there. And so going back to how this affects menopause, it's just, I see such a gamut of women. And I'm so really passionate about this, especially women, because I talk to women all the time who've either had a stroke, they feel like they're on the verge of having a stroke. I've talked to women all the time about this. And one of the things is that we just do not think it will ever happen to us. We think it will happen to everyone else around us. We try to do whatever we can do to prevent our parents from having this situation, from our siblings from having this situation, from our spouses from having this situation, our kids, but we never take care of us. Never take care of us. We are always on the back burner. And even it's so interesting to me that even after we suffered a stroke, how we still put ourselves last. Even though we now have this model in front of us, we see where this can ultimately end us, but we still put ourselves on the back burner. We still put ourselves last. We don't take our medicines on time. We don't adhere to the prescriptions that we have. We don't eat right. We don't, there's just so many modifiable things that we can do. We can stop smoking, stop drinking. There's just so many things that we can do to try to help us on this journey, but we're not willing to do that. And so that's one of the things that I do. I try to preach to every day, all day, prevention, because that is the only thing that if we're talking about later, we're going to go into menopause. We need to get this level part first, because once you add on menopause, it's like that is just something that's really, truly going to exacerbate all the situations and everything that we're going through.
Yeah, thank you for sharing your story. And I'm so glad you're sitting here to share that story. So thank you for that. Dr. Shanta Quilette, can you share your story?
Absolutely. And Dr. Christine just said a mouthful. I really appreciate her emphasis on putting yourself first. I don't know if y'all heard that song, Give Me 50 Feet, but that's why I tell people, give me 50 feet, stand behind me. You can only get my pour in overflow. But yeah, so here's my thing. So I went about 8 years being misdiagnosed, going back and forth to doctors. I was 38, 39, and 40. I've had 2 strokes and a heart attack. My stroke that I had on April 9th, 2019, I always say it's kind of funny because I did ask God and tell him that I did not want to be at work all day that day. And I say he's not petty, he's precise. And I lost, it's really crazy because I went into work probably feeling the best that I ever did in the past year. So 8 months before that stroke, I had a heart attack. And the day before my stroke, I went to my cardiologist. He told me I was all good. Everything looked great. All the things that were going on in my heart were minor, even though it was multiple things going on. I went to work hopeful. I went to work smiling. I went to work laughing. I was an IRS revenue officer at the time. And if anybody has ever dealt with a revenue officer, you know how that goes. And so I was just excited from, being off of work for so long and being able to file liens and take and file levies and seize property and all these good things. And I found myself at my desk, dizzy, speech blurry, vision, all those things, and I collapsed on the floor. My journey was outpatient, inpatient from 2019 to February of 2021. I was incapacitated. I basically had to learn how to talk, walk, and do all the things that I had did all my life. And so it was disheartening. The one thing is because I advocated for myself. I did my best, and I still was denied the opportunity of fair and equitable health care. It cost me 17 years of a job that I love so much. And so one of the important things I say in this is, women, you know your body better than anyone. And I think because I felt intimidated, I felt unheard, I felt unseen, that I let my doctor basically punk me out of good health. And so instead of going out to a different physician, I kept on with that physician until another one told me, hey, I would not go to him anymore. That's all I'm going to say to you about that. So I say, and let me ask you a question real quick, because we talking about menopause, and I just done got some brain fog. And what was the last part of the question?
I don't mean to laugh. I don't mean to laugh. I just asked. Let me find the question. Hold on. Because I done scrolled down. What you want Black women to understand about that connection between blood pressure, stroke risk, aging, and menopause?
Yes, is that you need to know your numbers. It is important for you to know your numbers at every facet. Blood pressure, cholesterol, A1C, all those things, because all of those put you at risk as a stroke, with the stroke, and as a perimenopause, and as with someone that's with perimenopause, it also increases your cardiovascular risk. So when you go to the doctor, you need to be very conscious of how you speak with them. You need to be very knowledgeable when you receive that information, and you stand 10 toes down in receiving that. I always say, get a first, second, third, fourth opinion. Take a lie detector test to the office if you need to, but do what's necessary to protect your health, because you only get one of them. And as Kristin said, we tend to put everybody else on the back burner. We have time to do everything but what's best for ourselves. We put our doctor's appointments on the side. We don't take our. And here's the part about being an active participant in your rescue. The doctor will give you advice, and some of us don't take it. We don't adhere to it. We don't take our medicine on time. We don't take our medicine when we're supposed to. We don't keep up with our doctor's appointments. We don't eat right. We're fighting with our bodies. So you have to be an active participant in your body, in your health, but also knowing that you don't have to suffer in silence. It's okay to talk about what's going on with you. Culturally, we like to keep things quiet and on a hush hush, and we don't like to talk about family history, which is very important. And talk to your mom. Like, my mom didn't really talk about menopause, but when I started asking her questions about it, she talked about it. She talked about it. She said, yes, I had this, I had that. I didn't deal with this as much as I dealt with that, but we were able to have an open conversation. So I say, take care of yourself, and lipstick looks so much better when you're alive.
Amen. Amen. That's a whole word right there. Thank you for sharing that. And as always, I am so glad you are here to share your story too. So, bringing up the both of the stories we just heard, it seemed like there was a consistent, like, kind of symptom of the dizziness, the palpitations, or and they didn't mention it, but I'm just assuming maybe shortness of breath. Dr. Eboni and Dr. Kim, how can women tell the difference between, okay, this is a cardiac moment versus a menopausal moment? And what should they be asking the doctor when they go to the doctor?
Yeah. So I usually tell my patients the 3 S's. If it's one-sided, if it's severe, and if it's sudden, it's likely not menopause. If it persists, I also, and I love what she just said about making sure that you are active participant, because I always tell my patients for many years, from the moment I started practicing medicine, is that this is a team approach, right? I need you to do the work. I need for you to report back the data in order to best treat you. My plan, my medication, these things work when I have the right data. If I prescribe you a medication and you don't take it, but you come back to me for a follow-up for me to see, am I going to take you off, or am I going to, increase? You haven't done the work, right? So it is a team approach, and that means that you have to start paying attention to those symptoms, as I stated before. If it's sudden, right? Does it go away? I need for you to track these things. Is it severe, right? Is it one-sided versus another? Those could be the difference between something that is a cardiovascular issue versus something that's just straight menopausal. Palpitations that just don't go away, right? If we're going to have them, if you're dealing, some people will have them in menopause, but if they're not going away, it could technically be a cardiovascular issue. Fainting. A lot of people will actually experience sudden vision changes as well. Those are certain signs of actual cardiovascular issues as opposed to menopausal issues.
Okay.
Right. Yeah, absolutely. So I echo that. I think the confusing part is that a lot of these symptoms overlap and they blur together. And so I typically, with menopausal symptoms, usually if you're experiencing like hot flashes or night sweats, usually the symptoms, they rise and fall between 2 to 5 minutes. Anything longer than that is concerning. Also, if you are doing any sort of activity, such as walking up a flight of steps, and you are out of breath from that, and compared to before where it wasn't an issue, that's like an efficiency problem. There's a problem with your heart actually pumping the way that it should. Also, if it's traveling in your jaw, your neck, your shoulder, like Dr. January said, if it's one-sided versus the other, some numbness involved, then those are some red flags and you need to get help as soon as possible. It's also always good to have like a baseline echocardiogram, echocardiogram, EKG. A lot of your primary care docs will do it in the office just to have a baseline, because if something were to happen, you would need to compare it to see if something changed regarding your heart health. So that's always a good baseline to just have when you are well enough. So if something happened, you would be able to compare it.
Okay, thank you. And one thing I want to make sure to bring up before we run out of time is a lot of people, a lot of women, they want to get on HRT, but then there's that confusion around the hormone therapy replacement. And, yes, there's been a lot of it linked to, in previous conversations we've talked about where it used to be linked to certain cancers or things like that. But what about the confusion that seems to be coming up around hormone replacement and heart health? And what should women know about the timing, the risk, benefits, and who should have a deeper conversation with their doctor about it? Dr. Eboni.
Yeah, and I love that you brought that up. The fact of the matter is you need to know if you are a good candidate for HRT, right? Not everyone is a great candidate for HRT. This is a deeper dive conversation with your doctor. So I'm just going to give you some examples of individuals who may not be a great candidate for HRT. If you've had an existing breast cancer or uterine cancer, not a good candidate. If you've had a stroke, if you have, underlying heart conditions, you probably aren't a good candidate. And, with that black box warning that we discussed on the last virtual panel, is that when we looked at that black box warning, it was with individuals who were over the age of 60. So when you talk about women who get on HRT within the 10 years of, the menopausal transition, it could be cardioprotective. So estrogen can help with your cardiovascular issues, but we want to make sure that you are a good candidate. Remember that data, you have to be a teammate. We need to know if you're going to a new doctor, if you move, we're in that stage where, we move and leave from one doctor to another. You need to have your medical records. You need to know your history, because those things will help us to dictate if you are a great candidate for HRT or if you're not a great candidate. Women over the age of 60 with underlying conditions, not so much. Is one of those timing things as it pertains to HRT. But remember, we talked about the different supplements that you can take. If you're not a candidate for HRT, there are various supplements that you can take.
Okay, thank you. Dr. Darlene, what realistic lifestyle changes or wellness strategies can help women support their heart health while also managing these annoying symptoms?
Well, before I answer that, I just want to echo a follow-up on something that Dr. Eboni said.
Okay.
Yes, it is true. Also, I think blood clogs is also another symptom that you want to report to your doctor, because that could be something that prevents you from taking HRT. But there's also, for women that are over 60, okay, I'm not new to HRT, but we are now finding that it is safe as long as they're healthy, and they may not get the cardio protection, but there are other benefits like women. I have clients that are in their 70s that still have hot flashes. So they were in that group where they stopped taking HRT because of the fear, and now they're asking if they can take it. So it is a relevant conversation you should have with your doctor. If you're over 60, you're healthy, and you're having some other symptoms like still having hot flashes, or you need it for bone support. So I wanted to just, caveat that. Now I'm having a menopause moment. So what was your question again?
Now we all in the same boat. I think we're all in the same boat. What was I asking? What realistic lifestyle changes or wellness strategies can help women support their heart health while also managing these symptoms?
So, as a former athlete, I think a lot of these lifestyle changes are just something we should do for general good health, right? Mm-hmm. Not just related to heart health. So as I said earlier, what does your eating regimen look like? I think what I find is most women don't consume enough protein. Even if you are plant-based, you can still consume enough protein because you want to maintain muscle, and not just because it looks good or you're trying to lose weight, but it plays a significant role in your overall health as well as your brain health and your heart health. So the heart's a muscle, right? So you want to make sure you're eating appropriately. And the best eating regimen, I always tell women, think about the Mediterranean diet because it's plant-based, lots of healthy fat, lots of healthy fiber. When it comes to fitness, it's unfortunate, but we have to kind of do it all. You still need your cardiovascular exercise, but it doesn't have to be anything crazy like I do. So I'm a cyclist. I still cycle, 80, 90 miles when I do ride. However, I think someone said it earlier, you can exercise for 30 minutes and you don't have to do it all at once. So I call it exercise snacks. If you can do 10 minutes in the morning, 10 minutes midday, 10 minutes in the evening, and it might mean instead of sitting at your desk all day, you stand up, you do some squats, you do some wall push-ups. If you have access to some resistance bands, you do some curls. So you can fit exercise in, but it doesn't have to be the standard way most women think about exercise, and it doesn't have to be time consuming. And I like to use the word movement versus exercise because sometimes when you say the word exercise to women that aren't accustomed to exercising, it doesn't motivate them, right? So it's movement. It's if you got a garden. Or, everything that you do can be a part of that movement segment. And then, as I mentioned before, sleep is critical. If you're not getting good sleep, I think as a part of your morning regimen, your circadian rhythm is reset when you get sunlight in the morning. So as a part of your morning rituals, journaling, prayer, or breath work, getting out and getting some direct sunlight, that helps reset your circadian rhythm. And then having a sleep routine, something that, you set up at night where you're relaxing, you're not scrolling all night. I think we're all sort of guilty of that because we're so used to having our phones and these digital devices, but it activates the brain. So you want to put those things down in a timely manner and you want to get your sleep because it's critically important. And then I think I heard someone say this, and we all know this. So tobacco, alcohol, just not good in general. Alcohol tends to make night sweats worse. So if you're experiencing that, check in to see if it's related to something you ate or something you drank. That was one of my challenges. I used to like to have my little alcohol with my girlfriends when we go to brunch. And I'll be honest with you, I was going through a stage where I really didn't want to listen to my body. I said, oh, well, the wine's not working. Let me go for the vodka. And the vodka's not working. Let me go for this, because I wasn't connecting the dots. And then I realized that, when I don't have alcohol, I don't have night sweats. And it took me a minute, but eventually I just eliminated it from my complete regimen. And I feel so much better and I don't miss it. And it's been like 3 years now where I don't miss it. I go out with my girlfriends, I have my mocktail and I'm happy. Yeah. So, making those type of changes and be intentional about them, but not getting overwhelmed, I would say are the things that you want to focus on, and don't try to do them all at once. Find that one that's a priority. If it's sleep, focus on that. If it's diet or nutrition, focus on that. If it's stress, focus on what are your practices that are going to help you relax a little bit more or regulate your system. And then, as you dial those things in, go to the next one and the next one and the next one.
Thank you. And I will say mocktails are delicious. They are. They are. So as we close out, I want to make sure I get everybody here. What is one priority that every woman should embrace to protect her heart health and overall wellness during the menopause years? I'm going to start with Dr. Kim.
Yes. So I practice metabolic health on the side, and what I found to be really game changing for a lot of women going through the transition and trying to work on their insulin resistance is, if you have insurance, then getting connected with a menopause trained nutritionist or dietitian. I found that to be essentially really game changing for a lot of these women, especially with what Dr. Thomas had mentioned, the Mediterranean diet. That's usually the gold standard when people are speaking of this diet and increase in protein. So if I had to, that would be the one thing I would add.
Okay, thank you. Dr. Eboni.
The one thing I would say, because menopause and the symptoms are so all over the place. In order to have a comprehensive approach, because you're going to need that, as she stated earlier about, you know, do it in chunks, either exercise, manage your stress, manage your sleep, like all of these things you need. So in order to include all of these things, you have to manage your schedule. That means you're going to have to plan those doctor's visits. You're going to have to plan your actual wellness, your stress relief. You're going to have to plan your meals. You're going to have to plan, when you're taking your supplements to alleviate some of these symptoms. So if you can do one thing, it's going to be to manage your schedule. And that means management of your symptoms throughout the day. And that's the one thing that I would say.
Thank you. And I will, just to give an example, like every Monday and Friday on my calendar is blocked off. I'm going to yoga. Nobody bother me. The phone is off. Yes. Shanta, Quilette, how about you?
I'm gonna say become a bad patient, and I'm not saying bad is non-compliant. I'm talking about bad in stop being so good at shrinking yourself in medical spaces. Stop being so polite. Stop leaving your appointments with unanswered questions because you didn't want to take up too much time. The women who have survived, like me and Kristin, we were in a season when things got inconvenient for us. And so we ask follow-up questions and we keep asking questions, and also make one woman's appointment because of yours. So after you have your cardiovascular screening, your well woman, your numbers checked, your heart assessed, call somebody and tell them about it and say, I just went to the doctor and this is what the doctor told me. Now you go. Because women are dying from diseases that had warning signs that nobody caught. And so community accountability is everything. And it could save more lives than anything that these doctors can say on here today.
Thank you. That is great advice. Dr. Christine.
Yes, I will leave you with know your numbers. And that is checking your blood pressure numbers and knowing what those numbers are, especially when you're at home, not just in the doctor's office, because there's so many things, like she said, that can be prevented. But that blood pressure it's a sign. It's something that, will tell you that, hey, something's out of sync, something's not right. And it's interesting to me how many people say, well, I checked my blood pressure 6 weeks ago, or I checked my blood pressure a week ago. Your blood pressure can change every day. So you need to check your blood pressure every day. I check my blood pressure twice a day, every morning and every night. I've done it religiously. I keep a log of it. You have to know the patterns of your blood pressure. So I always preach, know your numbers.
Thank you. Great advice. And Dr. Darlene.
Yeah, I would say have a team, right? So we all know that this stage of life affects a lot of different parts of our body, and the medical community is still somewhat disconnected. So I would say make sure you have a primary care doctor that is focusing on longevity prevention. Make sure you have a gynecologist or a menopause specialist that might be just focusing on your reproductive health. Make sure you have a cardiologist. And then also mental health support is really important, because a lot of women get anxiety and depression when they have a decline in progesterone and estradiol. And then as Dr. Kim said, a registered dietitian, someone that understands nutrition and the specific needs of what women need when they go through this phase of life. And it's not just about weight loss. It's about healthy living. It's about thriving when you get to that age where you are retired, like I am, and you want to be doing all the wonderful things in life, and you want to still feel good, and you still want to be able to do those things.
Thank you so much. Great advice from all of you. I want to thank you all so much for joining me for this important conversation. I know I've learned a lot and need to make sure I know my numbers, and I hope the audience does too. Thank you again for having this amazing conversation. But for more information on menopause and heart health and just everything that we talked about today, you can head over to blackdoctor.com. There's articles and resources there. And I don't want you to go anywhere, because coming up next is our panel on fitness and movement. So stay tuned.
Thank you.
Thank you.
Thank you.
Thank you.